clarify that my name is Hunter Groninger. I'm a palliative care physician in Washington, D.C. in the United States at Georgetown University and at Washington Hospital Center, which is one of our affiliate hospitals. There are two topics I'm presenting today. One that my colleague and co-investigator Ann Kellerman is unable to be here today to present herself, but I was part of that study, so thankfully we'll be able to share her work, not as well as she would, but I'll do the best I can. And then the other topic is end-of-life experiences of patients with COVID-19 hospitalized and receiving hospital-based palliative care consultation. I think that what I'd like to do, just get the Zoom ready, is I'm going to, unless someone disagrees, I'm going to go ahead and start with the first one and kind of go through that and share that with you. And then some time for questions and comments, and then I'll move on to the second topic. So because they are different.
That's totally fine. Whatever you want to do, it's fine.
So let me pull up first. Okay, so I'm going to share my screen, and hopefully you can see it. Can you see slides?
Yes, we can.
Great. Okay, here we go. So this topic, this research that we've been working on here at our institution that I'm sharing with you, is the title of this is Sexuality and Intimacy Needs Within a Hospitalized Palliative Care Population. These are results from a qualitative study. I'm presenting it on behalf of my colleague, Ann Kellerman. I wish that Ann were here today. She's actually really been someone who has been I think a lead investigator in this topic in our field broadly. And if you look at the references, if you're interested to see that, she's published a fair amount on this topic already. Ann is our Director of Psychosocial Spiritual Care in our Department of Palliative Care here. She's also an Assistant Professor of Medicine at Georgetown. And I will share that this topic is an extension of her interest that started out. She is very eloquent about a case early in her palliative social work career where she met a young man who was diagnosed with a metastatic colon cancer. He'd had a variety of bowel surgeries, had an ostomy, and she was part of the consultation to help support him through his disease trajectory, realizing after a couple of visits that as a formerly very active individual who was relatively newly married, the biggest thing that was a barrier to him having the quality of life that he was hoping for was he was very afraid of physical intimacy with his wife. And he didn't know how to talk about that with anyone. Nobody had asked him about that before. And he was afraid even to bring it up with his wife. And it turned out that a big palliative intervention in that case was to work with him and his wife to be able even just to have a conversation about it and be able to bring this up as an important topic in his functional life and quality of life as he was living with cancer. So that got Ann really interested in this topic. And so here we are moving along. None of our study authors have any financial relationships to disclose. And this is the objective of our study. We were interested to explore patient concerns regarding intimacy as it relates to illness, family reactions, physician conversations, and coping strategies and challenges. And the background to this really is that most of the literature around intimacy in advanced illness comes out of oncology literature. Most of it is studied in patients who are living with cancer or who are cancer survivors and who are more functional in more of an outpatient setting. And so none of the studies have really looked at in depth patients who are hospitalized or repeatedly hospitalized or approaching end of life. And some of this early research that we've started to explore has been looking at this population to get a sense about how we could serve them better. Our study site was our primary clinical site, which is Washington Hospital Center in Washington, D.C. This is a 912-bed, very large tertiary care academic hospital in the middle of Washington, D.C. Our study population were inpatients who were receiving palliative care consultation. They were English speaking, so they could participate in semi-structured interviews, capacitated and able to complete a 30-minute or so interview. The process was semi-structured interviews that took place between November of 2017 and January of 2018. They were, after consent, were audio recorded, anonymized, and then transcribed. And then several of the study investigators independently read the transcripts using a grounded theory approach and constant comparative analysis. Were able to code and compare and then find relevant themes to discuss, which I'll share with you today. Just the results, just to look a little bit at the demographics of the patient population. Their median age in years is 63 years old, which really reflects our palliative hospital-based population here. Most patients were men, most were African American, also reflecting our patient population here. In the primary diagnosis, a lot of heart failure. I think that was, that's a reflection of, at the time of the study, that was a lot of our inpatient palliative consultative service for patients who had underlying cardiac disease. But we captured different underlying disease states. Here are some qualitative themes that came as a result of this. I'm just going to share the results with you. These were the 5 themes that came out of these semi-structured interviews during analysis. I'll talk about this in a little bit more depth. The first is romantic and sexual relationships. This is a topic that I think when most providers and most patients and most of our clinical literature look for how we define the word intimacy, this is what comes to mind most of the time. We found this in our interviews, we find this in existing clinical literature, and this was certainly an important part of our findings, thematic findings in this study. And you can see that in terms of romantic relationships and sexual intimacy for our patients, that this was a real point of discussion for patients and point of reflection for patients about their relationship to themselves and about their relationship to some of those around them. So some participants at one end saying, I can't have anything to do with that whatsoever, and that's just something that's no longer a part of my life. And then others reflecting that it's a very important part of my life, but I'm really trying to figure out how, in this new phase of my life, how am I going to integrate this into living with advanced illness. With family and friends, so again, like thinking about what does intimacy mean to different people, that for many folks, intimacy meant social and familial connections with individuals, and that living with an advanced illness actually it certainly impacted this definition of intimacy, and felt like in some ways that it enhanced opportunities for intimacy with family members. They had a chance to sort of reflect on who were family members who are now caregivers potentially, or who are deeply involved in their care, visiting them in the hospital, worrying about them, and in some ways had strengthened some of those relationships. Participants spoke frequently about provider communication, clinical provider communication. A common theme was that nobody had brought this up with me at all before. Some of them wondered why. Some of them felt like physicians in particular must think this is a taboo topic. It's interesting to us that some of the palliative care quality guidelines, particularly related to social work and psychosocial oncology, really recommend assessing patients' concerns around sexuality and intimacy, but this is not something that many palliative care providers actually feel comfortable doing. So this is a challenge that patients often experience and are sort of left wondering, kind of like when we often think about advanced care planning and advanced directives, the patients are wondering if the providers are the ones that are supposed to bring it up, and the providers are wondering if the patients are the ones that are supposed to bring it up. So nobody actually brings it up. And we found this out with a lot of patients. Some of the more concrete, specific detail, particularly in the patients with advanced cardiac disease, reflected on that their providers, who were in this case cardiologists and heart failure specialists, if intimacy was an issue, it was really related to any medication-specific interventions, let's say for erectile dysfunction, how is that going to impact my cardiology care? So very medication-specific, but not really interested, or from a clinician perspective, competent to bring up deeper issues that might be related to the patient's quality of life. This was interesting for us to learn in our results, that intimacy for some patients was really about intimacy with their with a spiritual life or with a higher power. That to them, when we sort of open-ended discussions about intimacy and what does that mean to you, that what was important to them was a reflection of intimacy as a reflection of their faith, and that their illness experience gave them an opportunity and sometimes some real challenges that they were confronted with in their spiritual life. So here's an example quotation from one of the participants. And again, it really reminds us that when we use terms of intimacy in particular, and allowing patients or participants in the study to tell us what they mean by that, what that term means to them, that there's so many different reflections to individuals of what that means, and we as listeners and hopefully as healers have to be responsive to meet patients where they are and not come with our own preconceived notions about what that's supposed to mean. There's some limitations to the study. This was done in a single setting, and the findings were certainly limited to what participants were willing to share. There may be many other issues deep below beneath the surface than we were able to touch on in this qualitative semi-structured interview study. But some of our next steps include really exploring more with patients how they cope with these changes and interventions that patients may find helpful to cope with changes to their physical body in relation to the concept of intimacy as it's meaningful to them. So in conclusion, patients with advanced illness, particularly those who are experiencing physical changes and challenges, really do experience changes to intimate relations, and providers usually fail to assess this. And so we, in the study, we really have some vivid illustrations of how intimacy impacts the experience of serious illness, and in turn is changed by the physical effect of the disease. Medical teams rarely address it, and participants really tend to describe relationships as prominent in adjustment to the loss of physical function. When you lose your physical function and more control of yourself and your life experience, and you begin to rely on others, it really puts into relief different, reframing of some of those relationships in different ways. And we're looking forward to exploring that more. Anne and I would definitely share, like to thank our co-investigators and absolutely the patients who are willing to share their stories. We think this is really meaningful work that we're continuing. And if you'd like to get more information from Anne, there's her email. And there are a lot of references at the end that I know we won't be able to go through, but a lot of ways to begin to look at that. So I will stop there. I think I'm going on time, and
Thank you, Hunter. That was very good. Very interesting. As you said, not many people studying it or even asking the question.
Yeah, it's really interesting. I'll just reflect kind of anecdotally, and this is me reflecting now, but I think Anne would agree that when some of her manuscripts were published a few years ago, it was really interesting. On the one hand, just to give some anecdotes, one of her studies was really focused on patients with advanced heart failure and a subgroup analysis of patients who have durable mechanical circulatory support, or LVADs, and thinking about, what does intimacy mean to these patients whose bodies have literally changed and in part become, part machine, and the impact that this has on obviously their whole life, but in this particular framework, one example that really came to mind that was important in our findings was a grandmother with an LVAD, And to her, intimacy meant being able to cuddle in the bed with her grandson. And now that she had an LVAD, she was terrified to do that because she was afraid, or he was afraid, that either of them would roll over on the drive line and some catastrophe would happen. So, you know, here she is with a big change in her life and what was meaningful to her in terms of a personal connection that she hadn't brought up with the heart failure team, nobody even asking her about. And so here she was, and that was some of the work that we were able to do. Interestingly, being able to share some of that data and those experiences with a larger, you know, heart failure audience at some of their scientific conferences, it was really eye-opening, I think, to the heart failure audience to sort of think about and begin to think about the consequences of some of their really important and often you know, helpful interventions, but that there are some negative or neutral consequences to those as well. And I also, again, just keep going back to the idea that we also found in some of those early studies that in more like kind of the social media arena, Twitter and so on, even within a hospice and palliative care clinician population, you know, some people who are really standing up and applauding, saying this is really important to do, and some people saying this is totally inappropriate, we shouldn't be asking these questions of patients, which was disappointing to us and surprising, but it also gives us a sense about how much work needs to be done, we think, in this arena. So I'll stop there and see if there are any questions or comments from the audience.
Any other questions? We seem to have had a very, very quiet audience here the entire day. Since I know two of the people, Karen or Judith, any questions? Nope.
I would just like to say, I think this is very interesting still. You know, the presenters today have all touched on really great things. So thank you. It's just one more in the list.
Yeah,
So,
I would
Hunter,
say something.
I would like to, I'm sorry.
Anne, can you hear me? Oh. Anne, can you hear me?
Yes, well, we can hear you, Judith.
Okay. Nobody ever addresses the role of the non-professional and the role of volunteers and what they might do, how they can supplement the professional, what role would they take? Would they require additional training? Anything like that? That's my comment.
So as you know, I think volunteers are very important. In hospice, volunteers actually do get formal training. And there are lots of volunteers and they get formal training. In palliative care, I'm not aware of places that are doing formal training.
On that same note, I wanted to ask Hunter about the training for the team that's actually asking these questions, because it seems to me that they have to be really comfortable with themselves about asking these questions so that they can create a comfortable environment, a safe environment for the patient to really be open.
Yeah, that's a great comment. I don't have an answer for you on how to do that yet. I think that's certainly part of Anne's research pathway. You know, first getting a sense about what's the groundwork, what's the lay of the land in terms of what are the issues and what are patients at, you know, in this kind of a obviously structured, consented setting, interested and able and willing to divulge and talk about. And you know, next steps would be both to, you know, not only to kind of get a sense from clinical providers about, you know, how to do this better, not just not in a research setting, but in a real, you know, kind of real-time setting, and also to get a sense from the patients more about what they want. You know, is it something that's important for them to talk about? Are they interested in people trying to address these issues? If so, how? I think they probably are interested in getting, you know, the option of being able to talk about this more, and you know, probably like a lot of what Dr. Berger's been talking about today, and a lot of what we do in the field is meeting people where they are without an agenda, trying to assess what their own needs and preferences are, and helping to the best of our ability to support those, getting those needs met.
So Hunter, I would assume that what Anne is probably going to go from here is from this qualitative work go to develop a tool, much like we did with the NIH Shields, because we took her from qualitative to a tool. And even if this is a short tool, she now has themes that she can develop questions to develop a tool.
No, that's exactly right, and that's, I think, some of the next steps that she's been interested in, where to go from here. Absolutely.
Keep her busy a few years. Okay, so the next lecture is going to be from Hunter Groninger again, and this one is going to be on end-of-life experiences of patients with COVID receiving hospital-based palliative care.
So I'm going to share my screen again, and I think you should see slides. Let me know if you don't. So this is a different project from what I just shared with you. This is our part of an ongoing is the pandemic, unfortunately, is ongoing evaluation of the role of what we do caring for patients with the novel coronavirus therapy. I'll say that, kind of as background, all of us here have been impacted by coronavirus in multiple ways, and will be for a long time. I don't know if some of you might agree or disagree, but sometimes I think of this of COVID-19 as in many ways an example of an ultimate palliative care illness, meaning that it can affect everybody. It can clearly affect not just individuals with the disease, but the family unit, the social unit, and so on. It has a unpredictable prognosis. It has symptoms associated with it. It really has challenged our ability to think outside of the box and provide something more than just straightforward medical care. We really need holistic care to meet the needs of these patients and their families. And so we were really interested in our hospital, which is, as I mentioned before, same hospital, large institution. We really had a lot of coronavirus patients in the first surge that happened in our region in the spring. It's all starting up again in the Mid-Atlantic United States region again now, to understand what is it that we're actually doing, where are we needed, how are we delivering our services, and are there ways that we could be doing it better. So this is a part of ongoing research as well. And I'll share with you what we've got so far. None of the authors has any financial relationship to disclose. And I just mentioned this myself, that we know ourselves, and we're seeing in the clinical literature that palliative care consultation really is an important intervention for patients who are hospitalized with COVID-19. Clinical guidelines are being introduced, but this is all happening so fast that data regarding all of it, including specifically hospital-based end-of-life experiences, really remain lacking. So we're really interested to see how we could contribute to that burgeoning literature. So this was our objective. We wanted to describe palliative care interventions and end-of-life experiences for hospitalized patients who were dying of complications of COVID-19. This was a retrospective analysis of patients with COVID. It was diagnosed in hospital, who were admitted to 3 regional hospitals between March and June of 2020. We chose 3 hospitals in our system. One is our academic medical center that I characterized in the first study. A second is an urban community hospital, and the third is a suburban community hospital. So we wanted to compare and contrast and look at those together and see, as we continue to analyze this data, what's available. All of these hospitals have robust inpatient interdisciplinary palliative teams. So we felt like across the board, patients who were receiving palliative care consultation were getting the same team-based approach that we do here. We extracted all the information from the electronic health record, which is the same at all the hospitals, regarding demographics, medical history, hospital course, complications, and clinical details of end-of-life care. And then specifically, we were interested in looking at symptom management strategies, where did the patient die, and palliative interventions that were provided during the patient's hospitalization. And so far, we've used descriptive statistics just to describe to you what we have so far, although we're beginning to look at some relationships between different groups. Here are the results. So among 227 patients who were admitted to all three of these hospitals during the study period and received palliative consultation, 109 of them died during the study period. And you can look briefly at the characteristics of them again. More men than women, generally an older age, but with a wide range in that age. Most patients were self-reported African American. That's a reflection of the hospitals where we work. And you can see that a lot of these patients had concurrent comorbidities at baseline. And then among the hospital interventions while they were under our care, all the patients at one point or another received intensive care unit level care and for a median of 10 days. Most of them were intubated at some point. Many of them received renal replacement therapy at some point. And I think that a lot of my understanding is a lot of the COVID medical data that's coming out now is really showing a connection between severe pulmonary disease and kidney disease. There's a lot that goes on with fluid management in these patients. I'm putting for you just the COVID specific interventions that these patients received. We know now that, that a lot of these interventions are no longer in favor, but just to give a sense about what people were receiving over that early COVID period. Less frequently, they were getting remdesivir and dexamethasone because it was the end of the study period that some of the data was coming out, looking at the benefits of that. Of course, now, depending on certain admission criteria, patients are, at least in our hospitals, are often offered remdesivir and dexamethasone for disease management. So here are some of the results of what we found. And so these are the reason for consultation. Why was palliative care asked to come to the table? And I'll highlight a couple of things for you. Most of the time it was addressing in some way or another goals of care. At our hospitals, in our hospital system, goals of care means getting a sense from patient and families what are their decision-making preferences, what is their disease state awareness, what is their prognostic awareness. It does not automatically mean we're trying to move things in a particular direction or we have a particular agenda in terms of the trajectory of care. So it's really common for us to get involved for this reason. And then the results of those consultative efforts are really intended to be aligned with lining up what's medically feasible and what the patient and family preferences are. But also I think it was really important to point out, and this is going to be a recurring theme for the rest of my talk here, that patient and family support and counseling, nearly half of the patients for which we were consulted, that was the reason for their consult request. Non-pain symptoms, certainly with flourishing COVID-19, dyspnea, anxiety, and other associated symptoms were common. And then the very first one just says COVID. And I think for a lot of the patients who were hitting particular areas of the hospital, certainly in the ICUs, we determined together early in the COVID course that would be, just because of the uncertainty of the prognosis and high risk of mortality, that would be a good indication to consult palliative care earlier on. And you can see, interestingly, that on the far right of this, that end of life or hospice referral was actually a relatively small proportion of why we were asked to the table. And so I think some of that reflects our hospital and our collaborations with different services, that they know we're not just the end of life team, but as you'll see in all of these 109 patients who died in the hospital, that was a lot of the care that we ended up providing. This has been really helpful for us to reflect on retrospectively of the palliative interventions on our interdisciplinary team. We certainly did some non-pain symptom management, we did some pain management, but what we did the most of actually was psychosocial support and counseling to patients and families, which really shows the kind of the huge halo distress of what's happening in this pandemic. So even while patients are interested in and pursuing as many aggressive disease modifying interventions as possible, here are the patients in the hospital, in intensive care, intubated, and the families at our institution, and I think at most in the region, were really prevented from coming to see their loved ones. So the families are terrified and they can't see the patients. So that's a lot of the work that we tried to do, was at least to provide that level of support, which is really important. Among the 109 patients who died in the hospital, Most of them had sort of what we call full code or interested in CPR and ACLS interventions at presentation. And when they died, almost all of them did not have those preferences at the time of death. I think that at least speaks to the kind of the disease trajectory for these patient subpopulation that died in the hospital. Just looking a little bit at some of the medication interventions at end of life, almost all the patients received opioid therapies at some point, primarily for dyspnea, sometimes for pain, but mostly for dyspnea. And just to give a sense, as the disease changed over the course of the hospitalization, the first 72 hours, patients in this population had a mean of 171 milligrams of oral morphine equivalents, with that range in the first 72 hours. And in the final 72 hours, 415 milligrams. You can see like a threefold increase in opioid requirements during the hospitalization. They're the three top opioids prescribed. Why does that matter? Well, it really mattered here because at different times during the pandemic, there have been opioid shortages around the country and regionally and in our hospital. And sometimes we had to get really creative with how we were going to manage symptoms. Looking at those, I don't know, I'd be curious to know if others have had these kinds of experiences. I think we were sort of stunned and haven't really been able to explain the really high oral morphine equivalents needed to manage symptoms for these patients. And I think that, across the board, that's really kind of making us think about what is the underlying process and from a pulmonary perspective, how do we manage dyspnea better as we kind of continue or prepare for the next round. About half the patients got benzodiazepines, about less than 20% got antipsychotics at end of life. Some of that is related to our hospitals who are really kind of nervous about using parenteral antipsychotics outside of the ICU. And when these patients were dying on the floor, we were more likely to use benzodiazepines for agitation, even though that might not be our first line choice. So in conclusion, at this point, hospitalized patients dying from COVID-19 really get broad interdisciplinary interventions, but there really is an emphasis on non-pain symptom management, not too surprising, and supportive counseling, not surprising, but really important to underline. And that has, to the second point here, our early outcomes really identified some clinical practices that should be continued and opportunities to develop. And for our clinical service, that really has helped us rethink how we are mobilizing our inpatient palliative care team resources. Where do we need our social workers and chaplains to be involved early on? Where do we need to have our prescribing medical providers early on? And that's actually helping us right now as we launch into the second round to think about how we're deploying folks. So in this case, more of our medical providers are kind of assigned more to the medical and surgical floors, where patients are more getting kind of like, I guess, an inpatient hospice type of experience, end of life care, and that's their focus, and really doing opioid and other medication titration. In intensive care, where we're really kind of emphasizing psychosocial and spiritual interventions, because the intensivists are intubating and sedating these patients. There's not a lot of intervention, a lot of conversation to have with the patients at the time, but a lot of work to do with the families who, again, are not able to visit their loved ones. I want to thank all my co-investigators and all the other folks who are helping us pull data and analyze data in our patients and families that are inspiring us. If you want to contact me, there's my contact info. I'll stop there. I guess I'll
Thank you,
open it up.
Hunter. That was very good. Are there any questions? So in regards to the guidelines, I absolutely agree with you. And needless to say, when the first set of guidelines came out of NIH and there was no mention of palliative care, I responded immediately and wrote to both Henry Mazur and Cliff Lane, who had written the guidelines, and I said, this is really not appropriate because palliative care is definitely right out front, with COVID. Interestingly, with the COVID patients that we've had in our unit, and as you probably could guess it's been very few, 2, 3 at a time, because it's people transferred there for remdesivir or whatever trial they're doing at the time. They never contacted us. So they not only didn't put it in the guidelines, they never contacted us. And, you know, I said, look, everywhere else in the country and in the world, palliative care is stepping up to the plate and actually educating other professionals to do primary palliative care with these patients, because it's so many patients. So maybe we'll get there. As you probably have guessed, I don't let up until they'll finally do it. I go, okay. And maybe if, you know, you get studies like this out, I mean, just numbers, they're going to go, oh, you know, feel free to send it to me. I'll send it to Cliff Lane and Henry with another note, because it wasn't.
Yeah. I was just going to say, related to that, I think you know, it's telling that story is something that we're just like you, we're really interested to do. One of our, I didn't talk about here because it's not this particular study, but one thing that we've looked at retrospectively is we happen to get consulted for we're an ECMO center, and a lot of the severely ill COVID patients with pulmonary failure, sometimes cardiopulmonary failure, will come to our hospital for ECMO, which is a big challenge, limited resource, and there's a lot of uncertainty about what's the ECMO course for these patients. And we happen to get consulted on all of the patients who came here with coronavirus who were cannulated for ECMO. And looking at that data, which is under review, the manuscript is under review. One thing that we're also interested, we looked at those who survived and those who died, and what did palliative care do? Were there differences between the two groups? And there actually weren't. What we were doing, we were doing the same interventions with those who survived and those who died. And we ended up presenting that to the cardiac surgery group here and saying, look, if you get us involved, it doesn't change the outcome of the patients in terms of their mortality. So there's a lot that we can offer, but you shouldn't be worried about us being involved with your patients. And that, thankfully, that was really successful. So now we're actually automatically consulted on all the ECMO patients who come here. So, Dr. Berger, you're right, like being able to capture that data, analyze it, and share it with people in the language that they need to hear so they can feel reassured about us being involved. They shouldn't need that reassurance at this point. Palliative care has been out there, but some of them do. And that can be really helpful to move the field forward.
Now, in terms of the dyspnea issue, I think that opiates and benzos is actually not the treatment. I think we have very little study on that. And I think people with underlying lung disease, like we see in COVID, where their lungs look terrible on X-ray, it's just not the best treatment. Whether it's non-invasive ventilation or other things, opiates are not only not the best treatment unless they're very, very, very end of life and you're just trying to, provide some comfort, but some of that is it making them sedated or, I'm not sure it's actually working on the dyspnea like we thought it might initially. And I think we take that just because of the few rare studies that we had on like cancer patients, but it's not the treatment of choice, I don't think, and definitely more research is needed in that.
I agree 100%. I think, these were patients who were at end of life. And I think that, so that's, part of that, you're right, extrapolating data from what we know in other disease states. I think that there's a lot to learn about COVID. And I guess, anecdotally, I think a lot of us here were thinking these really high opioid requirements for these patients. That sort of signaled to me that just what you're suggesting, that opioids are probably not going to be the best dyspnea therapy for this patient. It's what we got, it's what we know. We have to learn more. And so that didn't signal to us like, this is great. It signaled to us like, this is what we got, but we probably need to figure out how to do better because the COVID isn't going away.
Like there has been a trial with COPD and, opiates actually can decrease survival. So I think with underlying lung damage, it's not going to be the treatment of choice. And
Agreed.
we don't have one study, so.
I don't have a question. I was just going to contribute and really wanted to sing your praise because it's so important. I work in hospice and seeing patients at home. So they're, have made the choice very often to come home from the hospital. And the families really are in crisis. They were in crisis because they couldn't see the patient. And now they have them home and they're faced with, having to take care of them and risking getting the virus themselves. So it's a really difficult time and we need more support and more research to those families to be sure. So thank you for that good work.
Thank you for the comment.